Okay, so met a few of you already. I'll introduce myself again. I'm Donna Rowsie. I work in the pediatric side, Amber, so we'll be looking for you to come down there and see some peds psych patients. So Tiffany Chatham was supposed to do this presentation with me, and she was unable to be a part of this. So, but anyway, what I'm hoping to have you guys learn from this, those of you that work in pediatrics or will be coming to work in pediatrics, is basically to understand the management differences between new onset in DKA, new onset not in DKA, those that are previously diagnosed in DKA and previously diagnosed that are not. In addition to that, when we started insulin infusion and understanding the forbidden carb ratio correction factor, which throws everybody off. But it's something that we will get through during this lecture, I promise you. So kids are just small adults. We've kind of heard that, right? I mean, they joke about that a little bit in PALS, talk about why that's not necessarily so, but you have heard that, right? Kids are just small adults, and so in some ways they are, but with physiologic and anatomic changes, they're clearly the same in some regard. But when we're talking about things like this, especially DKA, if you treat a kid like you treat an adult in DKA, complications can result to a very end point of badness. So basically, this is the main thing that you want to know. The reason of the difference between the two is that we manage pediatrics in DK with insulin, not with fluids. So you won't hear me talk at all about fluids, 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 push, 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 because these kids need lots of fluids. What these kids need is restrict, 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 and then we give fluids. Does that make sense? So at UVA, we talk about kids versus adult. When do we treat them like adults? So really what you want to take from this is that if they are in pediatric ER, if they are in DKA, if they're going to the PICU, no matter how much they weigh or how old they are managed as a pediatric DKA patient, okay? Pediatric protocols, pediatric order set, everything that the PICU would be doing, that's what we're going to do as well, okay? So sometimes when they get to the age 18, they try to transition them over to adults. There's some parents that kind of kick and scream and say, please, please, one more year, please, I want to just follow peds endocrine once more. But usually it's about 18 when they transition over to adults, and it's a wake-up call for a lot of them because they have been in this mode of coming into the ED and getting restricted for fluids, and all of a sudden now they're 18 and a half, 19 years old. They come to the adult side and it's like, bam, 2 liters of fluid, insulin, and it's a very difficult transition for the families as well as the patients. So pathophys, this is kind of funny. Just because I threw these up here just because I was going to talk a little bit about it, but Jen and Angela both do such a tremendous job of talking about the pathophys. I can't imagine that anything that I say would make sense. So I just put the slide up there because it looks nice. But if you guys want me to talk about, you know, the sort of glyconeogenesis, it's a waste of my time because I'm not real good at that part. So pretty much keeping it simple because that's what you want, right? Very simple. So urine output, poor indicator in DKA. Poor indicator as far as hydration goes. And when a kid is hyperglycemic, their kidneys can't reabsorb all that extra glucose that's there. So the excess spills over into the urine. Because of osmosis, pulls water in, then you have water, electrolyte, and vomiting that now further complicates the whole dehydration process. So if we give a lot of fluids to these kids, or we give it too fast, then what's going to happen is you have this sort of dramatic fluctuation in the osmolality, and when that happens, you have increased risk of cerebral edema, which in the long run can be death in these kids. So that's a scary thing sometimes when we're talking about it, because I think people get really concerned about, well, how much fluid is too much and how much is too fast, and am I going to be the responsible one that causes problems in these kids? Well, unfortunately, it's 24 to 48 hours after too much fluid or too aggressive of fluid that you see these changes take place. The reason for it is not well understood. There's a ton of literature out there. There are a lot of articles that talk about cerebral edema and why it happens, and it's not well understood. As I said, there's a lot of theories about it, but what we do know is don't do it. Don't give too much. Don't give it too fast. So the criteria, the indications for treatment, pretty much as it is, it's similar to the adults. Diabetes diagnosis greater than 200. Most patients come in with polyuria, polydipsia. They have weight loss usually. We don't know about their A1C until obviously after we've gotten some blood from them. DKA defines pH less than 7.3 and a bicarb less than 15. So, what do we do with some of these numbers initially? So the pH we'll talk about because that's insulin. Bicarb less than 15, what do we do with that? Well, adults are going to give bicarb, right? Especially when it gets to certain numbers. Do we give bicarb in pediatrics? No. Not as a push, not as an instant extra bolus. We give it in a buffered solution. So there have been times before where some peds patients have gotten IV pushes of 25, 50 milliequivalents of sodium bicarb. That is also one indicator that can cause or increase your chances of cerebral edema. So fluids and bicarb together are two big things that you want to try to avoid, okay? And these are not things that you have to know yourself. You need to look at the protocol, look at the cards that I'm going to be discussing, look at the worksheets that we have in PEDS, and all these things will help you to discuss with the physicians, this is what we should do. We shouldn't give too much fluid here. We probably shouldn't do this or do that, okay? So let's look at a new onset. This is what the order set would look like. This is kind of what you should expect to see. IV access and labs, HCG for pubertal girls. Fluids initially are 10 cc's per kilo. That's just like nothing, right? That is nothing. And a lot of times what you'll see is that doctors or nurses or physicians are thinking we need to give more. The kid comes in, they've had weight loss, they're dry as a chip, they've been vomiting, they look dehydrated, their mouth is dry, they've been peeing a ton. They look like they need about 40 per kilo, but we keep them restricted. So 10 per kilo first, and then if you have to bolus them, it's going to be because they're shocky, right? Or they need to have resuscitation. Then you're going to do the insulin infusion based on what your labs. And then you're going to do these maintenance fluids, which is calculated on a 4-2-1 rule. So if you work in PEDS, you know what 4-2-1 rule is. If you don't, check with your preceptor. You should be going over that now as you're there. Let's see here. So the insulin infusion always starts there. Is that right? Everybody's familiar that works in PEDS? Always at 0.1 units per kilo per hour. And only under that is if you're 24 months or less. Okay? Once you start insulin infusion, you should be getting a blood glucose 30 minutes after it starts and then every hour. We're working on a worksheet right now. We actually have a worksheet, and it's an old worksheet that Dr. Woods created. It's been revised, and this is what it's going to look like. So you may find this in the basket in PEDS where we keep the DKA worksheet. So just be looking for that soon, a new one at least. So do we ever go up on the insulin or down in PEDS? Everything's different between adults and PEDS. So would you go up on the insulin or down? No. Same with adults. Never go up on it, never go down on it. I have been in the ED for 18 years. I've been in the PICU for 10, and I've never seen an insulin drip higher or lower than 0.1. Okay? This just talks about your fluids a little bit and about the K, and those are going to be clear on the protocol and the order sets as well about what to do when their potassium is less than 6 or greater. The 1.5 maintenance rate, that may not make sense to you right now, but we'll talk about it when we do the case study. Okay? So far, so good? Okay. So this is what you will see on the order set. As well as the card, not the cards, but the worksheet. This is where I think people get a little bit confused, but there's such a thing that we have, and it's called a 2-bag system. And so what the 2-bag system means is that initially when the kid comes in and you find out what their lab values are and you give them 10 per kilo, the first bag of fluid that you're going to hang is half normal saline with 30 and 40 of your additives, okay? And then you're doing your hourly checks, your AccuCheck, and your chemistries, and your venous gas. And then you find out that their blood glucose gets below 300, but still within the 200 to 300 range. Then you're going to add a bag of fluid, which is going to be your D10 with the same additives, okay? So I know that may not make perfect sense right now, but it will when we talk about the case review. But the 2-bag system is because we're using the insulin to correct their acidosis. We're using the fluids with the buffered solutions to help control their blood sugars and their electrolytes, of course, but primarily that. Then, of course, if it gets below 200 is when you do 1.5 maintenance just at the D10 rate. So a little bit not so clear. We restrict them initially by giving them 10 per kilo. Then we start their insulin, and then we say, oh, let's run them at 1.5 maintenance. So that doesn't make a lot of sense, but it does when you think about the electrolyte disturbances, and the dehydration is well defined after you get your blood work back. So starting the insulin will fix the pH, hopefully, and the bicarb. The fluids with the additives and the buffered solutions will help control the electrolytes and the rehydration. Okay? So that just, this is just sort of an addition to that. You know, you don't want it to go any lower than 100 per hour, and your goal is between 100 and 250. So how do you manage that? What if you come in and the kid's initial blood glucose is 400, and then it drops to 200 or 250 within the first hour? Well, that's way too much. So then what you might see, and it's possible, but sometimes every physician is a little bit different. We're trying to get them all on the same page. What you might see is, instead of running your maintenance fluids at 50% from one bag and 50% from the other, they may up the dextrose because he dropped way too fast. Is that clear? Sort of? Okay. So this was a pretty good example of the little girl that I just had just a few minutes ago, because she came in, she's 10 years old, she's 84 kilos. Wow. So we gave her 10 per kilo as a normal saline. We got her blood work back. She was not acidotic. She was tolerating clear liquids okay. So what we did for her is we went straight to the carb ratio correction factor for her. So brand new diabetic, did the same sort of thing that you do for everybody else by checking labs and giving her a little bit of a bolus first while you're waiting on labs, and then you go to the carb ratio correction. So now we just need to fix her, but she's definitely a diabetic. She's got some issues that need to be corrected, but we don't need to do all the special solutions. We don't need to start her on an insulin drip. Okay? So far, so good. And this just goes through the same thing that I just talked about a minute ago. Previously diagnosed, but they're not in DKA. So then we get to this. So those that work in Peds, have you seen it? Makes somewhat good sense. So this has always been the same for each kid that comes in. There's a place where you start in diabetes. So the endocrine folks that manage these kids as an outpatient, if they tell them that when you're at school, you need to correct for the amount of food that's on your tray, that's why they have these standard ones right here. Okay, so if this person up here that just came in who's 10 years old, and the doc says, so when you go to lunch in the cafeteria at school, you're going to get a unit of insulin for every 10 grams of carbs. So if her tray is 60 grams of carbs, she gets 6 units of insulin, right? She also has to check her blood sugar right before she does it. So she checks her blood sugar, and then she has to do this mathematical calculation, which we will do on the case study. Okay, so that's how they do it like that. Now this little girl threw me off just a little bit, like it will everybody else. So she's 10, she's obese. She is going to be a unit for every 10 grams of carbs, but the endocrine guy says, let's do a unit for every 30 over 150. And why is he doing that? Because she's just 10 years old, she's barely pubertal. She doesn't have puberty signs yet, but she's still obese. So he's going to correct her just a little bit more. So you'll see some variation, but as long as you know that this is kind of the standard, this is the normal, then it'll help. So example, switching over to the 6-year-old. I don't know if anybody wants to take notes to see if it helps you with it or not, but 6-year-old in DKA comes in with a blood glucose of 280. DKA has been resolved. A meal is provided, it's 90 grams. Okay? So then the next step, to figure out what your carbohydrate ratio is for that age group, your carb ratio, a unit per 15 grams. So take your 90 grams divided by 15, and that gives you your 6 units, just like we said. All right? Then the next level is, this, I'm just adding on to it as you see. Then for her glucose, it's going to be your target blood glucose minus the correction factor. So 280 minus 140, right? Divided by, you see where we are so far? Yeah? So you're going to come up with 2.8 units rounded, always rounded to the nearest unit, so 3 units for her. So one more step to it. 6 plus 3 is 9 units of insulin to be given before she consumes her tray. So what if you give this girl her tray and she looks at it and she says, I don't like it. I don't want to eat it. And she's only going to eat half of that. So now you're giving her 9 units of insulin for the 90 grams, but she's only consumed 45. So what are you going to do?
You should not give it right away.
So endocrine really wants us to do that. And I'll be honest, as a school nurse, I do have a lot of kindergartners come through that have to do this, and they are not trustworthy, as everybody knows. So that's probably the only group, preschool and kindergarten would be the only group of kids that I would sort of slide away from this just a little bit, because Amanda's right. You can't trust them to eat what's on their tray, so what I might do is just have them start eating it, give them their insulin, not beforehand, but if they don't consume the whole thing, then I look at their tray and say, okay, well, it looks like maybe 45 grams they didn't eat, so let's see what we can find for 45 grams. Make up the difference, even if it's apple juice. That's a lot, but it's still going to be something that will make up the difference for what you gave, okay? So she also would need Lantus. So we try to give it in the ED. If not, it can be given in the PICU. Everybody gets 0.25 units per kilo. If they've had it at home, if this is a known diabetic and they got it within the last 4 hours,